Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY4 resident at the University of Pittsburgh, and today we will be continuing our discussion of gynecologic cancers with an overview of endometrial cancer. Endometrial cancer is the most common gynecologic malignancy in the U.S., accounting for just under 4% of all cancers seen in the U.S. It's typically a diagnosis of older age with a median diagnosis around age 63, so typically affecting postmenopausal women. It's uncommon in patients that are less than 45 years old. The most common histology for endometrial cancer is typically adenocarcinoma. So in our last talk, we focused on cervical cancer and kind of contrasting the two. Remember, cervical cancer is the most common gynecologic malignancy in the world, but its rates have significantly declined in the U.S. due to preventative vaccination as well as screening. And so that's why endometrial cancer tends to be more predominant. Cervical cancer typically affects women of a younger age. They're often premenopausal, often in their 40s, whereas with endometrial cancer, we're dealing with an older population. And then remember, cervical cancer is usually a squamous cell carcinoma. It can be adenocarcinoma, but usually it's squamous. And then for endometrial cancer, because it's arising from the endometrium, most commonly the histology is adenocarcinoma. And the main risk factor for endometrial cancer is going to be unopposed estrogen, which we'll talk about a little bit more down the road. Just like we did with cervical cancer, we will divide our discussion on endometrial cancer into two parts. In this overview lecture, we will focus on presentation, workup, staging, and a management overview. And then in the next talk, we will dive more into the actual evidence and the seminal trials that are important to know for endometrial cancer. So let's start with some basics of presentation, workup, and staging. 9 out of 10 times, endometrial cancer is going to present with postmenopausal bleeding. So any bleeding after a woman has gone through menopause is considered abnormal. And typically this is how endometrial cancer presents, just because it does typically affect postmenopausal population. Other symptoms may be present if the disease is a little bit more advanced. So that might include abdominal pain, pelvic pain, distension, urinary or rectal bleeding if the tumor is extremely advanced and invading into those nearby structures, or constipation. Sometimes patients will actually have a history of either hyperplasia or atypia. So complex hyperplasia is really just excessive growth of that normal glandular tissue, and that's associated with around a 3% risk of malignancy. And then complex atypia is actually abnormal cellular morphology, so atypical cells, and that's, as you can imagine, associated with a much higher risk of malignancy of 30 to 40%. In terms of workup, on the board exams, you're always going to start with a complete history and physical, focusing on the pelvic exam. For labs, you might consider obtaining a CBC, especially if they're bleeding a lot, check their blood counts. You might consider things like LFTs or CA-125. A key imaging to obtain is the transvaginal ultrasound. So when a woman presents with abnormal bleeding or something like postcoital bleeding or postmenopausal bleeding, we typically want to obtain a transvaginal ultrasound to assess the thickness of the endometrial stripe. And if that endometrial stripe is abnormally thickened, that should prompt us to get a biopsy. So one way to get a biopsy is to do biopsy under hysteroscopy, but sometimes that can be non-diagnostic. And if that's the case, we might need to do a DNC, which is a dilation and curettage. Now, once we have a tissue diagnosis of endometrial cancer, keep in mind that this is a surgically staged disease. So most patients are actually going to go for a hysterectomy up front, and we will talk more about the type of hysterectomy and so on during our management section. But typically after we, present with bleeding, get that transvaginal ultrasound, get a biopsy, and if it's endometrial cancer, we take them for surgical staging, and any further imaging is based on the surgical stage. So if patients have a high-grade tumor or if they have more advanced disease, we would get further imaging after the surgery, and that would include at least a chest x-ray or a CT chest to rule out distant metastases. And especially if it's high-grade, we want to get that CT chest, abdomen, pelvis. If we're concerned about nodal involvement, we might get a PET CT. And sometimes patients are not always going to be operable up front, either for medical reasons, they're not good candidates to go to the operating room, or for surgical reasons where the disease is kind of too advanced. And in that case, we would get an upfront MRI to look for the local extent. But think about getting an MRI really only if the patient is not going to go for an upfront surgery. If they are amenable to surgical staging, then we first do the surgery and then we think about risk factors and whether or not we need to get further imaging. And usually that next imaging would be a CT chest, abdomen, pelvis. In terms of risk factors, we talked about patients sometimes having a documented history of either complex hyperplasia or atypia or atypical hyperplasia. But going further back than that, what makes endometrial tissue even grow abnormally? And the answer to that is unopposed estrogen, which we mentioned earlier in this talk. So there are many different risk factors that can lead to unopposed estrogen. And they're kind of divided into different categories. So in terms of physiologic risk factors, things like obesity, nulliparity, having early menarche or late menopause, these all increase the exposure to estrogen. There are certain exposures as well that we think about. So things like unopposed estrogen therapy or treatment with tamoxifen, which is a selective estrogen receptor modulator. So remember that in the uterus, tamoxifen actually acts as an agonist. It acts as an antagonist in other areas, but in the uterus, it acts as an agonist. Pathologic risk factors are things like diabetes mellitus or polycystic ovarian syndrome. And then a big genetic risk factor to be familiar with is Lynch syndrome or HNPCC. Remember, this is an autosomal dominant condition that's associated with gene mutations in our mismatch repair pathways. Especially in women that are diagnosed with endometrial cancer at a young age, so less than 50 years old, we should consider screening for HNPCC. Let's take a moment to talk about the anatomy of the uterus. So we know that the uterus sits in the pelvis, and the body and the fundus of the uterus kind of make up the upper 2/3. The lower uterine segment and the cervix make up the lower 1/3 of the uterus. The uterine wall consists of a few different layers. So the innermost layer of the uterine wall is the endometrium, and this is the glandular tissue from which endometrial cancers arise. And that's why most of the time endometrial cancers are adenocarcinomas. If we go beyond the endometrium, the next layer in is the myometrium. So the myometrium is a muscular tissue, and cancers that arise from that area are known as uterine sarcomas. And then one more layer out, we have the serosa, which kind of lines the outside of the myometrium. Beyond the serosa then are all of the ligaments that support the uterus. So that includes the broad ligament, the uterosacral ligament, and the transverse or cardinal ligament. There are two important terms that I want to define because they come up in the staging. And these are the parametria and the adnexa. So the adnexa are the tissues that are right immediately next to the uterus, adnexa. So these are the things that are kind of theoretically attached to the uterus, right? So the fallopian tubes that kind of connect the ovaries to the uterus. So think of the adnexa as those tissues that are right next to the uterus, or the tissues that are kind of literally attached to the uterus. So the ovaries, the fallopian tube, and then the broad ligaments that kind of encompass those tissues. The parametria are the rest of the connective tissues that are around the uterus. So the ligaments that kind of anchor the uterus into the pelvis. The reason these terms are important to define is because they come up in the staging. And for now, I just want you to remember that parametrial extension is a little bit more advanced than adnexal extension when it comes to staging for endometrial cancer, right? The adnexa are right next to the uterus, the ovaries, the fallopian tubes. And so those are a little bit less advanced compared to parametrial invasion, which is more advanced. The regional lymph nodes for the uterus include the bilateral parametrial regions, obturator, internal and external iliac, common iliac, presacral and sacral nodes, And we also include the para-aortic lymph nodes because the fundal lesions, so lesions that are closest to the top of the uterus, can actually drain directly to the para-aortic nodes. This is uncommon, but something to keep in mind. Let's talk about the pathology of endometrial cancer. So remember that we obtain pathology on that initial biopsy, so whether it's done through hysteroscopy or through DNC. And then if patients undergo surgical staging, we can get some more information about the cells using the surgical sample as well. So that initial pathology is obtained just as a biopsy, and then further pathology is obtained at the time of surgery, and that gives us some more tissue to work with. So when we think about endometrial carcinoma, most of the time, the type of cell that we're thinking about is what's called endometrioid endometrial adenocarcinoma. This is also known as type 1 endometrial adenocarcinoma. Type 1 or endometrioid cancers are graded based on their degree of non-squamous or non-morular differentiation. So morular cells are those well-circumscribed, well-differentiated cells that make up the glandular tissue of the endometrium. And what we're looking for is the degree of abnormality or that non-morular growth pattern. So as that percentage of abnormal cells or that non-morular growth pattern increases, so does the grade. So less than 5% or less is grade 1, so that's the lowest amount of abnormal cells. Up to 50% makes it grade 2, and then greater than 50% makes it grade 3. So this is the most common type of endometrial cancer, and this is kind of typically what we are describing, and this is known as type 1 endometrioid endometrial adenocarcinoma. Most of the endometrial cancers you see will be type 1, and they're graded based on their degree of abnormal cells. So grade 1 is less than or equal to 5%, grade 2 is 6 to 50%, and grade 3 is greater than 50%. The other type of endometrial adenocarcinoma is known as type 2 cancers. And the histology for type 2 cancers is more aggressive. These are usually serous or clear cell tumors. And keep in mind that with endometrioid or type 1 histology, the grade is depending on the degree of abnormality, right? But with type 2 histology, it's always considered a grade 3 because these are more aggressive histologies. So if it's serous cell or clear cell adenocarcinoma, then it's always going to be a grade 3. One thing that is sometimes noted on the pathology is something called the MELF, or microcystic, elongated, and fragmented pattern. That is considered a poor prognostic factor, and having this pattern actually raises the grade by 1 for grade 1 to 2 tumors. So if it's a grade 1 tumor and it has that MELF pattern, it's going to be a grade 2, or if it's grade 2, then it'll turn into a grade 3. So that's endometrial adenocarcinoma. We always classify it as either type 1 or type 2. Type 1 is endometrioid histology, and it is graded depending on the degree of abnormality. Type 2 is serous or clear cell, and it's always considered grade 3. Now let's move into the sarcomas. So one type of tumor that you might encounter is what is known as a carcinosarcoma. And historically, this was classified as a malignant mixed Müllerian tumor, but it's really a carcinosarcoma, and this is just treated as a high-grade endometrial cancer. So if you see carcinosarcoma, just think high-grade, grade 3. And then finally, we have uterine sarcomas. So remember, these are the cancers that are actually arising from that myometrium, that's the muscular wall of the uterine wall. And uterine sarcomas are very high grade, they're very aggressive, and they're rare. They are classified as either non-epithelial versus mixed epithelial, non-epithelial, and they technically have a separate staging system and treatment paradigm. So for the purposes of this talk, we're really going to focus on the endometrial adenocarcinomas. So for endometrial adenocarcinomas, just remember that there are mainly 2 types of histology, type 1 endometrioid versus type 2, which is serous or clear cell. Type 1 is graded on a scale of 1 to 3, and type 2 is always going to be grade 3. And then remember that MELF pattern is poor prognosis, and it increases your grade by 1. Other than just the type of histology under a microscope, something that's really important to look for in the pathology report is a comment about LVSI, or lymphovascular space invasion. Lymphovascular space invasion is basically when cancer cells are visualized in the little lymphatic channels that surround the tumor. These are the channels through which cancer cells are actually going to be traveling through the lymph nodes. So the channels that connect the cancer itself to the nearby lymph nodes. And so you can imagine that if we see a lot of cancer cells inside of those channels, so in those lymphovascular spaces, then our risk of nodal involvement or future nodal recurrence is going to be high, right? Because if we see the cancer in the roads that lead to the lymph nodes, then you can imagine that we expect the risk of lymph node involvement to be high. So LVSI is an important thing to look for in the pathology report. And there's actually there's a few different approaches for grading LVSI, but I think the most common one, the one that was used in the PORTEC studies, which we will talk about in our next lecture, they utilized a 3-tiered approach for grading LVSI. So the 3-tiered approach was no LVSI at all, meaning no cancer cells seen in those channels. Focal LVSI, defined as just one focus of LVSI that was around the tumor. And then finally, substantial LVSI, where there is diffuse or multifocal locations of LVSI. And in the PORTEC 1 and 2 pooled analysis, substantial LVSI was the strongest independent factor for pelvic nodal recurrence. And so the reason I point this out, it's important to look for LVSI and whether there's none, focal, or substantial LVSI on the pathology report. And depending on the presence of LVSI, as we will see when we go over the treatment paradigm, there is some consideration for actually escalating therapy. So pay attention to LVSI on those pathology reports. Across more and more disease sites, what you'll find is that nowadays we are not just concerned with what the cancer looks like under a microscope, or in other words, its histology. With advancing techniques in science, we're better able to elucidate certain genetic and molecular features of tumors. And as we're able to get more information about that genetic and molecular profile, we're starting to use that to kind of classify tumors and also decide if we can use these features to kind of better tailor treatment. So endometrial cancer is actually a great example of this because there have been 4 distinct molecular subtypes that are defined, and we know that these subtypes are prognostic, which means that they predict survival. What we're trying to figure out through ongoing studies, which we will talk about in the next lecture, is can these molecular features actually be predictive? So can we use them to predict response to particular types of treatment? So those studies are kind of ongoing. So what are these molecular features? So they are pol E mutated, microsatellite unstable, copy number low, and copy number high. So if you take a given tumor, you can test for the mismatch repair deficiency. And if that is present, then they are mismatch repair deficient and they fall into that microsatellite instability group. If they are MMR intact, then we look for a pol E mutation. And if that is present, they fall into that pol E mutant group, which is, remember, the best prognosis. And then finally, if they're not in either of those categories, we look for P53 expression. And if they are P53 wild type, they are called copy number low. And if P53 is abnormal or mutant, it's considered copy number high. So if you take a look at the Kaplan-Meier curve, you can see that if we just look at these different molecular features and look at the overall survival, there's clearly a separation. So pol E mutant have the best overall survival, and those that are P53 abnormal or copy number high have the absolute worst prognosis. And then microsatellite unstable and copy number low kind of fall in between. But pol E mutated is the best and copy number high is the worst. So we know that these molecular features are prognostic and they're very important to be aware of. And in ongoing studies, what we're trying to figure out is, can we better tailor our therapy based on these molecular features? So since the pol E mutated groups perform so well, is it possible that maybe we're overtreating them and we can kind of de-escalate therapy? And then since those copy number high patients do so poorly and their survival is so low, do we maybe need to escalate treatment? And so that's kind of what I mean when I'm talking about tailoring therapy based on these molecular features. We're actually looking at the molecular features, seeing what the prognosis is, and then now in these ongoing trials, which we'll talk about in the next lecture, we're kind of trying to decide, are there certain groups that can benefit from either de-escalation or escalation of therapy? So for now, just keep in mind that there are 4 distinct molecular groups for endometrial cancer. And remember, pol E mutated is the best prognosis and copy number high is the worst prognosis. So now that we've talked about some important considerations on pathology as well as those molecular features, let's get into the staging. Now, remember we said that endometrial cancer is a surgically staged disease. So whenever possible, as long as the patient is a good candidate to go to the operating room and their disease is not so advanced that the surgeon feels that they're surgically inoperable, we always try to take them for upfront surgery once we get that initial biopsy. Staging for endometrial cancer is a little bit complicated. There was a recent update in 2023 and things became a little bit more complicated. We started incorporating degree of LVSI and grade and things like that into the staging. We have always used the anatomic stage plus the histology and the degree of LVSI to kind of guide our treatment. But in the 2023 FIGO updated staging, they actually, I think, made it a little bit more confusing by incorporating those factors into the staging. I'm going to start by talking about the 2017 staging, just because this is a simplified way of thinking about it. And if you understand this staging, then you can pretty easily insert the additions from 2023 and still have a good conceptual idea of endometrial cancer staging. Also, in the next talk, when we go through some of those seminal trials and talk about the literature for endometrial cancer, all of that literature is based on historical staging systems. And so I think knowing the 2017 FIGO staging is helpful because then you're better able to kind of contextualize those older trials as well. So keeping in mind that this is a little bit complicated, let's first talk about how endometrial cancer was historically staged and do the 2017 FIGO staging. So FIGO stage divides endometrial cancer into 4 stages, and stage 4 is probably the easiest. So 4A, as with many other types of cancer, is when the cancer is invading into the bladder and or bowel, so those adjacent organs. And 4B is when there's actually distant metastasis. So that's pretty easy to remember. It's very similar to other cancers, including cervical cancer. The other thing that's very easy to remember, because it's identical to the staging system for cervical cancer, is that stage 3C category. So remember, 3C for both endometrial cancer and cervical cancer is when there are lymph nodes that are positive. 3C1 is when there are just pelvic lymph nodes that are positive, and 3C2 is when we actually have para-aortic lymph nodes that are positive as well. So stage 3C1, 3C2, 4A, and 4B are pretty much the same for both endometrial as well as cervical cancer. The things that are different are those lower stages. So since we're going in backwards order, let's just tackle stage 3A and 3B. So stage 3B is when there is either vaginal or parametrial extension, and 3A is when there is invasion of the serosa or the adnexa. And remember I said this earlier, that parametrial extension is more advanced for endometrial cancer versus just adnexal invasion. So those things that are the adnexa, or right next to the uterus, so the ovary, the fallopian tube, or that outer serosal lining, those are 3A. 3B are the more advanced, so lower down, so involving the vagina, or further out, so involving the parametria. And then finally, that brings us to stage 1 and 2. So stage 2 is easy. It's just if there's any invasion of the cervix. What's right below the uterus? It's the cervix. So cervical involvement is stage 2. And then finally, we have stage 1. And stage 1 is divided into stage 1A versus 1B, depending on the extent of myometrial invasion. In stage 1A cancers, the disease is limited to either the endometrium alone or less than 50% of the myometrial wall. So there's less than 50% myometrial invasion. Stage 1B is if there's greater than 50% myometrial invasion. So if there's 50% or more myometrial invasion, it's stage 1B. And sometimes on test questions, they might actually give you measurements in millimeters. So they might say that the endometrial wall is 12 millimeters thick and you have 7 millimeters of cancer. And so because, 12 divided by 2 is 6, 7 is greater than 50% myometrial invasion. And so that makes it a stage 1B cancer. And so for these early stage cancers, or these stage 1 cancer, it's really important to note whether the disease is limited to less than 50% of the myometrium or if it's 50% or above, because that's the distinction between 1A and 1B, and that does really affect our treatment decisions after patients have surgical staging. So just keep in mind that stage 1A versus 1B is less than versus greater than or equal to 50% myometrial invasion. Stage 2 is invasion of the cervical stroma. 3A is the serosa or adnexa. 3B is the vagina or the parametria. 3C1 is pelvic nodes. 3C2 is para-aortic nodes. 4A is adjacent bladder or bowel involvement. And 4B finally is distant metastasis. So that was the 2017 FIGO staging, which is relatively simple compared to the latest updated system that has come out, which is the 2023 FIGO staging system. The main difference between the 2017 and the 2023 staging system, I think, is for early stage endometrial cancers. So for those stage 1 and stage 2 endometrial cancers, the 2023 system now takes into account not just the degree of myometrial invasion, but also the grade of the cancer, as well as whether or not there is substantial LVSI. And so having a higher grade and having substantial LVSI tends to upstage patients. This theoretically makes sense because we know that higher grade, substantial LVSI are poor prognostic factors, and in our treatment paradigms, as you will see, we actually often escalate therapy based on the presence of these factors. And so now the staging system is kind of more up to date with that and kind of, taking this into account. I think for the most part, stage 3 and 4 are pretty similar to the 2017 system as well. Stage 4 has now just been divided into 3 different categories. So 4A is now invading the bladder or bowel. Stage 4C is if there's distant metastasis. And there's a different definition for 4B, which is if there is abdominal peritoneal metastases. So involvement of the peritoneum outside of the pelvis, so involving the abdominal peritoneum. That is the new 4B. So 2023 is a little bit more confusing. I'm not going to go through it in gory detail, but I'll just leave it here for reference and know that this staging system now takes more into account the grade as well as the degree of LVSI. Before we move to the management overview, I just wanted to show an example of endometrial cancer on an MRI. So a T2 weighted MRI, which is shown on the left-hand side of the screen, is probably the best way to visualize endometrial cancer. Same as with cervical cancer, the T2 weighted MRI is really helpful. You can see that the tumor itself, which is kind of the big arrow is pointing to the tumor, And there's arrows that show that there is some superficial myometrial invasion. Those are the arrowheads. And then the big arrow is pointing to the cervical stromal invasion. You can see that in the T2 weighted MRI, the tumor itself is sort of hyper intense compared to the surrounding uterus on this T2 weighted image. So this is just an example of a stage 2 endometrial carcinoma, and we can tell that it's stage 2 because it's invading into the cervical stroma. So at this point, we've talked a good amount about the presentation and workup and staging of endometrial cancer. And I think, if you get into the weeds too much, it can be quite confusing. But I think the big takeaways from everything that we've discussed so far is that, number one, endometrial cancer usually affects older women. Number two, it usually presents with postmenopausal bleeding, which prompts a transvaginal ultrasound and a biopsy. And from there, the disease is surgically staged. And once we have that surgery that's done, there's a few things that we look for that help guide adjuvant treatment decisions. If patients are very early stage and low risk, we can just observe. But a lot of the time they're going to have some higher risk factors, which we will talk about, that warrant some adjuvant treatment consisting of either vaginal brachytherapy alone or external beam radiation. And sometimes we also need to add chemotherapy. So let's move on now and talk a little bit about the management of endometrial cancer. And as we talk about the management, some of those features on pathology, like the grade and the type of endometrial cancer, as well as the presence of LVSI, will start to come into light, and you'll see how they actually impact treatment decisions. So as we just said, whenever possible, we try to take endometrial cancer patients for surgical staging. So that means they need to be medically operable, meaning that medically they are deemed good candidates and fit to go to the operating room, and surgically operable as well, meaning that their disease is not so advanced that the surgeon is afraid they're not going to be able to take all of the disease out. So as long as they're medically and surgically operable, the gyn-onc team will ideally take these patients for surgery. And the standard surgery for endometrial cancer is a hysterectomy and bilateral salpingo-oophorectomy, so taking out the uterus and the bilateral ovaries and fallopian tubes. Now, there's a few types of hysterectomy, and we did talk about this in the cervical cancer overview lecture as well, but there is a distinction between a simple hysterectomy, also known as a class 1 hysterectomy, versus a radical or modified radical hysterectomy. So in a class 1 or simple or total hysterectomy, we're really just removing the uterus and cervix, and the parametria are left intact. And a lot of time, this surgery is going to be adequate for patients with endometrial cancer when the disease is limited to the uterus. However, if there is gross cervical involvement or any disease extending beyond into the parametria and things like that, then we need to address the parametria. So a class 2 or a modified radical hysterectomy removes the uterus, the cervix, the upper 1 to 2 centimeters of the vagina, and involves a wide local excision of the parametria. And then a class 3, which is a radical hysterectomy, completely removes the parametria up to the pelvic side wall or sacral origin, and it also removes a little bit more extent of the vagina, so the upper quarter to 1/3 of the vagina. So keep in mind that there are different types of hysterectomy, which you might see referenced. Oftentimes, a class 1 or simple hysterectomy is going to be adequate for early stage disease. But if there's cervical involvement or involving the parametria, then we need to get either a modified or radical hysterectomy. Now, in the modern era, laparoscopic approaches are increasingly utilized. And when the surgeons are performing the hysterectomy, if there is high-risk disease, they might consider obtaining omental and peritoneal biopsies as well, just to make sure that disease has not spread there. And finally, in terms of lymph node sampling, it used to be that we would perform a pelvic lymphadenectomy for all these patients. But there was a study called the FIRE study that showed that sentinel lymph node biopsy actually has 97% sensitivity. And so nowadays, lymphadenectomy is more controversial, less commonly used, often reserved just for higher risk disease. And based on the FIRE study, we know that sentinel lymph node biopsy is, very sensitive approach and can spare patients the toxicity of pelvic lymphadenectomy. Once patients are surgically staged, based on what their pathology shows, we then actually put them into postoperative prognostic risk groups. And I've included a table from the ESTRO risk groupings. And as you can see, it's quite complicated. So there's a lot of things that we're looking for on the pathology, including the stage, the grade, and the degree of LVSI. To classify these patients. And we're also looking at certain molecular factors, if known, and trying to start incorporating those molecular features into risk stratification as well. Now, one thing I'll say is I find that these postoperative risk groups are a little bit tricky to think about just because the way that they're classified in ESTRO and ESCO is sometimes not completely aligned with the way that risk groups were classified in the seminal trials that kind of determined certain treatment paradigms. And so I think it becomes a little bit tricky when you focus too much on the risk group. In my mind, and I'm going to give a very kind of oversimplified way of risk grouping these patients based on the treatment that we end up giving them. And in this particular very oversimplified way of thinking about risk groups, there's only two things that matter, which is the grade and the degree of myometrial invasion. So less than 50% versus greater than 50%. So having a grade 3 tumor or having a greater than 50% myometrial invasion, both are considered high risk factors. So low risk patients are those patients that have grade 1 to 2 tumors, less than 50% myometrial invasion. And for those low risk patients, we feel comfortable just observing them after surgery because their risk of recurrence is very low. If they have just one of those risk factors, so either greater than 50% myometrial invasion or grade 3 disease, but not both, then they're considered high intermediate risk. And we do treat them with adjuvant vaginal brachytherapy because, as we'll talk about in a future lecture, we know that when these patients recur, they are most at risk for recurrence at the vaginal cuff, or the very top of that vagina where the uterus and cervix were removed. And so we treat them with just local vaginal brachytherapy to reduce their chance of recurrence at the vaginal cuff. So these are the high intermediate risk patients with either greater than 50% myometrial invasion or grade 3 disease, but not both. And then finally, if they have both of those high risk factors, then they actually benefit from pelvic radiation, just because they're more at high risk of not just a local recurrence, but also a nodal recurrence in the pelvis. So that's a very oversimplified way of looking at this, and it'll make sense too when we come back in the next lecture and actually look at the trials that establish these paradigms. But keep in mind that, when you're in practice, you might hear these risk groups talked about for endometrial cancer. And so know that these risk groups come from, postoperative prognostic stratification of patients, and the risk groups are based on pathologic features. And the most important pathologic features to keep in mind are the grade and the degree of myometrial invasion, so less than 50% versus greater than 50%. If they have either grade 3 or greater than 50% myometrial invasion, then they're high intermediate risk and they benefit from adjuvant vaginal brachytherapy. And if they are grade 3 and greater than 50%, so both of those risk factors, then they benefit from pelvic radiation. So here's a table from the ASTRO consensus guidelines on treating type 1 endometrial cancer. So that's that endometrioid histology, or type 1 endometrial cancer. And this is for early stage disease, so stage 1 to 2. And it basically divides these patients into 3 groups, just as we talked about. Now, keep in mind that this table is kind of based on the 2017 FIGO staging. So 1A is less than 50% myometrial invasion, and 1B is greater than 50% myometrial invasion. So just remember that grade 3 disease and greater than 50% myometrial invasion are both high risk factors. If you have both of those factors, or you have stage 2 disease of any grade, then patients benefit from external beam radiotherapy. Now, if they have just one of those risk factors, so they either have grade 3 or they have greater than 50% myometrial invasion, so either grade 3 or stage 1B, then they're kind of considered into that high intermediate risk category. And if that's all that they have is just either stage 1B or grade 3 disease, then we treat with vaginal brachytherapy to reduce their chance of vaginal cuff recurrence. However, if they have one of these high intermediate risk factors, and then they also have an additional risk factor, so that risk factor is mainly is substantial LVSI, that high risk factor. If they have substantial LVSI, then we upgrade them and give them external beam radiation. And that makes sense, right? Because we know that LVSI is involvement of those lymphovascular spaces, those channels that actually carry cancer cells from the tumor itself to the adjacent lymph nodes. So if they have a substantial amount of LVSI on their pathology, then we're really concerned about pelvic node involvement or pelvic node recurrence down the line. And so we treat them with upfront external beam radiation to the pelvis to kind of treat that nodal basin and take care of that risk of disease, basically. So keep in mind that if they have one of those high intermediate risk factors, so either grade 3 disease or stage 1B, then we give them vaginal brachytherapy. But if they have substantial LVSI, then we upgrade them and give them pelvic radiation as well. And then finally, we have that low risk group. So they have less than 50% myometrial invasion, stage 1A, and they have low grade disease, so grade 1 to 2 disease. Most of these patients are going to be fit for observation, and we'll talk about the trials and what that risk of recurrence is for those patients in the future. But these patients have a low risk of recurrence, and so we feel comfortable observing them. However, if they have certain intermediate or high risk factors, so for example, if they have intermediate risk factors such as a older age 60 or greater, or if they have focal LVSI, then we might consider offering vaginal brachytherapy. Also, if they have high risk factors, depending on how substantial that LVSI is, we might consider vaginal brachytherapy as well, versus some discussion for pelvic radiation. So this is kind of, in a nutshell, the treatment paradigm for early stage endometrial cancer. And I think this is the most important thing to kind of keep in mind is these 3 risk groups that emerge for early stage endometrial cancer. One thing I'll add here is that depending on the institution, when we're doing external beam radiotherapy, we often will consider adding a vaginal brachytherapy boost at the end of that pelvic radiation, just because we know that when endometrial cancer comes back, we know that it's most likely to recur at that vaginal cuff, so the very top of the vagina where they kind of sewed it shut after taking out the uterus and the cervix. And because the risk is highest there, we do think that these patients often benefit from adding that vaginal brachytherapy boost to the pelvic radiation. However, this is institution dependent and it's not always done. Now, when patients get sentinel lymph node biopsy, if they have positive nodes on sentinel lymph node biopsy, then that upstages them, right? So then they become either a stage 3C1 or 3C2, depending on where those nodes are located. But sometimes what we'll find is that on sentinel lymph node biopsy, these patients are otherwise early stage and they just have something called isolated tumor cells. So not a full, focus of tumor, not enough to call it a positive node, but just isolated tumor cells on sentinel lymph node biopsy. And I just wanted to share a retrospective paper that was published by one of my former co-residents that kind of establishes a nice treatment paradigm for what to do with these isolated tumor cells. So if patients are low enough risk, so stage 1A, grade 2, they can often just be considered for observation or considering vaginal brachytherapy if there's focal LVSI. If they have greater than 50% myometrial invasion, so stage 1B and grade 1, then we consider vaginal brachytherapy. And if they have any, higher grade disease, like 1B grade 2 to 3 or 1A grade 3 or stage 2, then we would do, external beam radiation as we would if they were in that high risk category. So far, we have talked about early stage endometrial cancer, and we really addressed the treatment paradigm for type 1 histology, which is that endometrioid endometrial cancer. But remember, there can be type 2 histology as well, those higher risk histologies like clear cell or serous cell histologies. And so how do we manage those? Here's a table from that same ASTRO consensus guideline on managing stage 1 to 2 disease with high risk histologies. So the overarching key, I think, for these high risk histologies is to add chemotherapy, usually platinum and taxane-based agents, so regimens like carboplatin and paclitaxel. And for stage 1A disease, if it's clear cell, we can often just do vaginal brachytherapy, and there's a consideration to adding chemotherapy. But all others that are going to be myoinvasive, we really do vaginal brachytherapy as well as chemotherapy. And then this is for stage 1A, so less than 50% myometrial invasion. But if we have greater than 50% myometrial invasion, so stage 1B, or stage 2 disease with that cervical involvement, then we're adding external beam radiation as well as chemotherapy. So just kind of keep in mind that for these high-risk histologies like clear cell, serous, carcinosarcoma even, the key is really to add chemotherapy in the adjuvant setting. And we have a lower threshold for adding external beam radiation. Now, for locally advanced patients, so these are stage 3 or stage 4 patients that have more aggressive involvement, right? So involving the adnexa or the parametria, or sometimes even invading into the adjacent organs like the bladder or the bowel. If they are able to undergo upfront surgery, then in the adjuvant setting, the recommendation is typically for not just external beam radiation and brachytherapy, but also chemotherapy. And in some of the clinical trials that looked at these patients, like PORTEC-3 and GOG 258, those trials utilized concurrent chemoradiation. But in practice, what I've often seen is actually a sequential approach where chemotherapy is given upfront to mitigate that risk of distant metastasis, and then followed by external beam radiation and brachytherapy. So this is also, I think, a little bit institution dependent. And, in this space, we are now also starting to utilize some immunotherapy. And so we'll discuss the evidence for that in our future talk on endometrial cancer evidence. But just keep in mind that for these patients that are locally advanced that do undergo upfront surgery, the key is that they are at higher risk of regional as well as distant metastasis. And so they do need addition of chemotherapy or some type of systemic therapy. Now, there are some patients that are quote unquote surgically inoperable. And that can mean different things. Obviously, if they have bladder or bowel extension, then that would require, a very, very extensive surgery, and it would not really be amenable to a hysterectomy. And so the recommendation would then be for kind of upfront radiation plus chemo, probably, just because we want to kind of spare those organs. We don't want to remove the bladder or the rectum, However, sometimes the disease is just invasive enough that it would actually require an upfront radical hysterectomy versus a simple hysterectomy. And remember, we said when there's extension into the cervix or the parametria and things like that, then we do need to perform a more extensive upfront surgery. The problem with radical hysterectomy is that it's much more morbid compared to a simple hysterectomy, because we're actually dissecting the parametria up to those bones, right, up to the sacrum and up to the pelvic wall. And so this is an institutional experience, actually, from my institution, UPMC. But, we've been doing this here, and it seems pretty, seems to have good results, where patients are actually treated with preoperative radiation plus or minus chemo. Sometimes they're treated with concurrent cisplatin, followed by brachytherapy, and then taken for surgery. And in the UPMC experience, 91% had no clinical cervical involvement at the time of surgery, 58% without pathologic cervical involvement, and all of the patients had a margin negative resection with a PCR rate of 24%. And so the 3-year local control of 96% was very good. Regional control was 89%. And so these outcomes are very good, and this is kind of an alternate option to consider for these patients that have very locally advanced disease who would require very aggressive upfront surgery, is to consider that preoperative chemoradiation approach followed by brachytherapy, followed by surgery to spare them the more extensive operation. There are certain patients that unfortunately would just never be good candidates for surgery because they have too many medical comorbidities. They're too sick to ever safely be taken to the OR. And so these patients are, if they have endometrial cancer, are classified as medically inoperable, meaning medically they're never going to be candidates for surgery. And there is a nice set of guidelines from the ABS. The first author is Schwartz, and they kind of outline the standard of care for these medically inoperable endometrial carcinoma patients. And I think in this case, their uterus was never removed, so they never had that surgical staging up front. And so the uterus is intact. And so for these patients, we definitely want to obtain very thorough preoperative imaging, including an MRI, using that T2 weighted image for guidance for brachytherapy, for 3-dimensional brachytherapy. And in this case, the applicator that we use is a tandem, so an applicator that actually goes all the way up into the uterus. That's the tandem. And then depending on the stage, we might use either a tandem and cylinder, or if it's actually involving the cervix, we might consider using a tandem and ring or tandem and ovoids the way we would for cervical cancer. But most of the time for endometrial cancer, the applicator is going to be a tandem and cylinder. So if you look at these guidelines from Dr. Schwartz and team, the recommendation is that for these low-risk endometrial cancers, so stage 1A, grade 1 to 2, less than 4 centimeters, brachytherapy alone is sufficient. And we aim for a minimum HRCTV dose to 90% of the HRCTV, so the HRCTV D90, equivalent dose in 2 gray per fraction of 48. So the EQD2 to HRCTV D90 should be at least 48 gray for these medically inoperable low-risk patients that are just being treated with brachytherapy alone. And then when we contour out the GTV, the D90 should be at least 80 gray. For higher risk patients, so these what would be considered kind of high intermediate risk, right, with stage 1A, grade 3, or stage 1B disease, or disease that's greater than 4 centimeters, we now add pelvic radiation to 45 to 50 gray, followed by a brachytherapy boost. And since we're giving that pelvic radiation, the target D90 for the HRCTV increases to 65 gray. If there is cervical involvement, then again, HRCTV D90 moves up to 70 gray, or if there's pelvic nodal involvement as well. So the tables on the right-hand side show some different potential dose fractionation regimens for brachytherapy alone versus brachytherapy given as a boost. But kind of keep in mind that, if the patients are very low risk, so stage 1A, grade 1 to 2, less than 4 centimeters, these would be the patients that we would be observing in the postoperative setting, then we can just treat them with brachytherapy alone with a target HRCTV D90 of 48 gray at minimum. However, if they have more advanced disease, or if they have cervical involvement or pelvic nodal involvement, then we start adding in pelvic nodal radiation followed by a brachytherapy boost. So this was a lot of information about what I think can be a pretty complicated disease site to understand. So I just wanted to take a minute to summarize some of the major takeaways from everything that we've talked about. So endometrial cancer, we know, is the most common gynecologic malignancy in the U.S., Everywhere else, it's cervical cancer, but in the US, we are fortunate that we have a good vaccination program and screening program, and so endometrial cancer has now taken precedence. It tends to be a disease of older women, and age is a big risk factor for endometrial cancer. Remember, with breast cancer, we typically think of young age as being a higher risk factor. It's the opposite for endometrial cancer, where older age is a risk factor. Whenever possible, endometrial cancer is a surgically staged disease. So patients should have a hysterectomy and a BSO, as well as a sentinel lymph node biopsy if it's indicated. And once they have surgical staging up front, then we do risk-adapted adjuvant treatment. So for early stage disease, the lowest risk candidates are candidates for observation. Remember, so if they have low grade and less than 50% myometrial invasion. If they have either grade 3 disease or greater than 50% myometrial invasion, then they benefit from a vaginal brachytherapy boost. And if they have both of those factors or stage 2 disease with cervical involvement, then they benefit from pelvic radiation. If patients have LVSI, especially substantial LVSI, that is a pretty big risk factor, and that kind of ups the ante in terms of what type of treatment that they need. Now remember, for locally advanced disease, as well as high-risk histologies like clear cell or serous cancers, we try to add chemotherapy. Next, we talked about patients that are not candidates for surgery. So patients that are deemed surgically inoperable or who would require a very invasive, aggressive upfront surgery, upfront chemoradiation and brachytherapy followed by surgery is certainly an option. And then for those patients that we know will never be candidates for the OR because they are medically inoperable or medically unsafe to be taken to the OR, we treat them with radiation alone. So the lowest risk patients, stage 1A, grade 1 to 2, less than 4 centimeters, are candidates for receiving brachytherapy alone, but everyone else will get external beam radiation followed by brachytherapy. So this brings us to an end of our discussion of endometrial cancer overview. In the next talk, we will dive more into the evidence for endometrial cancer and talk about some of the seminal trials that have kind of defined all of these treatment paradigms that we just went over. And we'll also talk about future directions, including incorporation of those molecular risk groups, as well as incorporation of immunotherapy for treatment of endometrial cancer. So hopefully this was a helpful overview and kind of gives you the lay of the land in terms of endometrial cancer. And then hopefully when we come back and really dig into that evidence, it kind of helps to solidify the understanding of where these treatment paradigms come from. Thank you so much for all of your time and attention. I appreciate it. Thank you.